It's my pleasure to introduce Dr. Jeffy Balul, who's the medical director of the Addiction Consult Services, who will introduce today's speaker.
Hello, everybody. Good afternoon. I'm so excited to present today's speaker, Dr. Bogdan Anton. Dr. Anton is a graduate of the University of South Dakota from their medical school, and he has been our chief resident in the addiction psychiatry this year. I had the privilege of working with him since he's been a PGY1 until now, and have been so pleased with the progress he had made as a resident on all aspects. He is a very well-diverse scholar and trainee. He had been assuming a lot of responsibilities in his training, had been on the ethics committee in the hospital, had been a delegate union for the residents, which is a great mission, and assuming responsibilities as chief resident in the addiction psychiatry this year has been a privilege to work with. What I would like to say is that we will lose Boggy, and I'm sad for that, as he will go on in July to University of Pittsburgh Medical Center to do addiction psychiatry fellowship. However, it's bittersweet because I know that all of us at one point will have to spread our wings and go, so fly, baby, fly. And here you go. Take it away, Dr. Anton.
Thank you, Dr. JV, for that wonderful introduction. So today we're going to be talking about the intersection between bioethics and psychiatry. While in medical school, I got a certificate in bioethics, and I've been on the ethics committee here since my intern year. So a lot of that has informed what we will be talking about today. Our objectives are to foster a nuanced approach to ethically complex cases in psychiatry, to understand and describe basic principles in ethics as they apply to psychiatry, and to develop at least a rudimentary framework to systematically assess ethically complex medical situations. I don't have any actual or potential financial conflicts of interest related to this presentation. However, there are other forms of conflict. So my morals and values could be very different from yours. Those are based on upbringing, cultural context, life experiences. You may strongly disagree with some of the things that I have to say today, and I would welcome your questions at the end, and I'm happy to talk about it afterwards as well. I'm really excited to be giving this talk today. This is the biggest audience I've had ever presented to, if you include all the folks on Zoom and perhaps on YouTube. All of this is just so exciting that I'm already short of breath and my heart is racing. My smartwatch is telling me that I'm working out, and truly, thank you all for being here and showing support. And finally, I do want to make a good impression. My program leadership happens to be here. It's not easy to try to teach something new to such a well-learned audience from different specialties and my colleagues. So it's important for me to make these disclaimers because even though they might seem obvious or superficial, they might affect the way that I give this talk and what I chose to include in here. So without further ado, what are medical bioethics? Well, to put it simply, it's the ethical, social, and logical issues that arise in healthcare. Most people here are healthcare workers, and you might already have an intuition of what is right and wrong. And this intuition, if you want to think about it in this way, those are your moral values. Ethics is exploring those intuitions from a somewhat objective frame and seeing what sort of consensus we can reach with others. Expanding our ethical awareness is important from many different points of view. It can help you avoid unethical behavior. It can improve your self-knowledge. It can improve your therapeutic skills. It can help you avoid legal issues. And it makes you a better clinician at helping patients and helping your colleagues as well. So just to test your moral intuition, please raise your hand if you think it's wrong to kill people. Okay, very good. So we all agree that it is wrong to kill people, so your moral intuition seems to be intact. Let's talk about the trolley problem, right? So you guys might have seen this before. There's a trolley that's barreling down towards 5 people who are tied down to a track. And there's a bystander, or you perhaps, there's a bystander who's happening to stand by a lever that if they pull it, they divert the trolley and it'll go on this alternate track where there's only one person who's tied down. Please raise your hand if you think that the bystander ought to pull that lever. Divert the trolley. Okay, most people, once again. So your intuition is probably telling you that 5 people dying is worse than 1 person dying, and you're absolutely right. But let's think about it from a clinical perspective. What if we have 5 people who are in critical need of organ transplants without which they will die? Would it be okay for a surgeon to kill 1 person in order to harvest their organs in order to save 5 people who need those? Please raise your hand if you think a surgeon should do that. Okay, so this is where, a relatively similar scenario, right? It's still 5 people dying versus 1 person dying. So how comes we're all saying that no, a surgeon should not do that, but here we're saying that a bystander ought to pull the lever? Well, this is where you might feel like moral intuition might not be sufficient in determining what is ethically justified in this case. The good news is that your moral intuition can be sharpened through practice. If you do feel conflicted now, let me try to help resolve some of that conflict. Consider that a doctor's duty is to first do no harm, whereas a bystander, a random person on the street, might not necessarily have the same duty. Also consider that a surgeon would have to use a healthy person as a means to an end, even if that end is to save 5 people. In the case of the trolley, pulling the lever and 1 person dying, that's an unfortunate side effect of saving 5 people. But if that 1 person wasn't tied down, that person dying is not critical to saving those 5 people. So the situations actually are quite different. This case brings up the possibility that maybe actions shouldn't be judged solely based off of their outcome. So this is where the idea of virtue ethics comes into play, that actions ought to be judged not only by the outcome, but also one's virtue, one's intentions behind the outcome. Virtue is a behavior that is showing high moral standards. That's the definition of it. Dr. Basil Varkey is an ethicist at the Medical College of Wisconsin, and he proposes 5 professional virtues that clinicians ought to uphold. Those are compassion, or having sympathy and concern for another's suffering; discernment, being able to comprehend what is obscure, or in my own words, being willing to grapple with nuance; trustworthiness, being honest, being reliable; conscientiousness, doing one's duty well and thoroughly, basically wanting to be good at your job; and integrity, having and consistently upholding strong moral principles. Notice that integrity in and of itself implies that there is the possibility of learning and growth. Because as I said earlier, morality is something that you can learn. And this is echoed in our ACGME milestones as well. Ethical principles fall within the bounds of professionalism. So this is not just me saying this or the authors from my resources. This brings us up to the idea of positive and negative duties, the duty to do something or not do something respectively. Negative duties, generally speaking, tend to override positive ones. So, for example, you might not be strongly expected to always tell the truth, but you are expected to not lie. You may not always be expected to be donating to charity, but you are expected to not steal. You might not be expected to help someone in need, but you are expected to not, intentionally harm somebody. So in the case of the organ harvesting from earlier, there is a positive duty to save 5 critically ill people, but there's even a stronger negative duty to not harm 1 healthy person. These are the 4 main principles of bioethics that we'll come back to again and again throughout this presentation. Those are autonomy or self-determination. This is where informed consent and confidentiality come into play. Beneficence, the idea of doing good. This is where we are treating patients and trying to act in their best interest. Non-maleficence, or doing no harm, trying to avoid injury and suffering. And justice. This is probably the most esoteric of the 4 principles and encompasses quite a lot. It's the equitable distribution of resources, so that it can include access to care, responsibly using hospital resources, treating patients approximately the same, so not having favorites or discriminating against patients, and it also includes the legal system. Now, you might have heard people say before that something feels unethical. When people say that, they're probably picking up on the fact that one of these four principles is being violated in one form or another. That sense of wrongness is worth exploring further because looking at issues through an ethical lens allows us to grapple with the ambiguity and nuance of situations that we often come across in medicine. We should also try to consider the fact that these principles hold different values in medicine, right? There's a sort of hierarchy that is shaped by our culture. So for example, in the United States, autonomy tends to carry a lot more weight than in a lot of Asian countries. And we should take those differences in culture into account when treating patients with different backgrounds from our own or different backgrounds from most of the patients that we tend to see. So the hierarchy can be shaped by culture, but it's also impacted by the situation at hand. So let's return for a second to the scenario of organ harvesting from one healthy individual to save 5 people. What if that one individual was to use their autonomy and say, I want this to be done. I want you to take my organs in order to save those 5 people. Does that change what the surgeon should do? I won't ask you to raise your hand for this one, but the principle remains the same, that there's a strong negative duty to not harm somebody, even if they're asking you to do so, for a justifiable or laudable end of saving 5 people. So this brings up the idea that non-maleficence sometimes can override autonomy, even though we tend to hold autonomy up in the highest regard, at least in the United States. I would like to suggest a 5th principle for making bioethics more practical, and this is to consider your personal motivations. And I think you should be aware of your personal motivations just as much as these other 4 main principles that we had discussed. So personal motivations are factors that are impacting one's decision for reasons related primarily to oneself rather than primarily to the patient. And those can include biases, basic needs, higher level needs, and life history. So biases are prejudices either for someone or against someone. Those can be conscious or unconscious. It can be based on skin color, accent, gender, clothing, patient's BMI, if they have an active addiction or if they even have a history of addiction, people who use foul language, all those things can influence us. And we have basic needs, we have a need to be safe and not be assaulted by our patients. We have a need to be well fed and not, be hungry, not be too hot, not be too cold, not be too tired to work. And there's higher level needs, right? Like wanting to be well liked, wanting to make a living, wanting to work on big projects that maybe are, distracting you from your day-to-day work, wanting to spend time with your family. And there's also life history, which is major events that may have left a mark on you. This can also include previous patient cases that you have had, or perhaps how you've seen colleagues act in such situations. So this brings us to the simple and straightforward framework that I would like to propose in order to help you make decisions in an ethical manner. In essence, I'm just asking you to consider, or even put it down on paper, the main principles in medical ethics and your personal motivations when you come across challenging situations. So let's apply this framework to a patient case of mine from not too long ago. Now, I have changed details of this case in order to protect confidentiality. Also, this is a stock photo from PowerPoint. That is not the actual patient. But this is KM, and KM is a 23-year-old Hispanic male with a history of unspecified psychosis who was brought to UMass Emergency Department by police on a Section 12 after sustaining a scalp laceration during a physical altercation with his parents. Now, for those of you who are not familiar with Chapter 123, Section 12 of Title 17 of Part 1 of the Massachusetts state law, placing someone on Section 12 basically means that they can be held against their will for mental health reasons. Patients are not allowed to leave until they are evaluated by a psychiatrist at a mental health hospital. So KM is here on a Section 12. His vitals are normal. He denied any substance use. He had a laceration on the back of his head that the emergency medicine physicians had stapled shut. And he told staff that my parents took my car keys away because they want me to move out of the house. I'm going to give you guys the information a little bit out of order just to make it easier to make sense of it. But according to the parents, so this is collateral collected from them, KM became increasingly distraught about his parents hiding his keys away from him. Now, KM's parents swear that they did not do this. They did not take his keys away. They think that KM might have misplaced them. And if that was the case, it wouldn't be the first time that that had happened either. He reportedly attacked his mom with a broom as part of this incident. At some point, Dad came home and KM became even more aggressive. The father tried defending himself and ended up calling the police. KM came to our emergency department. Dad needed to go to a different emergency department. He required x-rays, and so he needed medical clearance as well. However, the parents see this incident as a quote-unquote misunderstanding. They asked that KM be allowed to return home. In fact, Dad is in the waiting room right now, and he's waiting to pick up his son, and he's been here for hours. Other pertinent history is that KM is relatively healthy. Up until 2 months ago, he didn't have a medical history, really. He did have a psychiatric hospitalization 2 months prior in the setting of self-dialoguing and excessive religious fasting. And that was the first time that was ever happening. This was concerning for first-break psychosis, so he was admitted psychiatrically at that time. He did not take any medications while he was hospitalized. He was focused on discharge throughout his whole time there in order to work on his plan. And after about 2 weeks, there was a court-ordered discharge, and he was discharged home with antipsychotic medications that he never took. On psychiatric interview, KM initially denied any violence. He then minimized the violence, saying, "I didn't hit them, I just pushed them away. This was in self-defense after my dad, quote, hit me in the head with a chair, WWE style." And then he quickly escalated to saying that he did try to hit his parents and in fact punched a hole in the wall while trying to hit his mom. Parents, though, say that we don't know why he keeps saying that. There's no hole in the wall, but they do say that he became physically aggressive. KM was adamant that his parents were trying to mess with him in order to get him to move out, saying that they took his keys because they want him to move out, which doesn't really make sense. I asked him about his average day, and KM said that he works on his plan. I asked him what the plan was, but he said that's rather personal. He doesn't want to talk about it, but that he's in the thinking and writing stage of that plan. Now, I am assuming that this might be the same plan that he was discussing at his previous hospitalization 2 months ago. But he denied spending any time with family or friends if he could avoid it. He's not employed, he's not going to school, and he's living with his parents. These are kind of signs that might make us concerned for negative symptoms of psychotic disorders such as schizophrenia. And throughout the interview, he was discharge-oriented, asking like when he might be able to leave, what's taking so long, what else do you guys need in order for me to go home? On mental status exam, you're noticing athletic Hispanic male who appears his stated age. He's dressed casually, but his t-shirt is soaked with blood, and he's got 2 staples from the laceration that was repaired. Interestingly, he is euphoric, inappropriately so given the circumstances, but his thought process was overall goal-oriented. He was guarded, and he would use humor excessively. Seemingly, the more uncomfortable a topic was, the more he would try to joke about it. And he was hesitant to share any quote-unquote personal information, and his definition of personal was very broad. He wouldn't tell me if he's spiritual or religious, for example. He refused to give us permission to reach out to family for collateral. He appeared to be responding to internal stimuli when not engaged in conversation. He appeared to be self-dialoguing and laughing to himself. He had these delusions of persecution, again, feeling like his parents are kind of out to get him, out to trying to mess with him, trying to frame him. And he was occasionally noted to be touching himself suggestively, having his hand down his waistband. He would be redirectable, but staff had to keep reminding him that that's not appropriate to do in the emergency department setting. And he was also disoriented to year, and wouldn't believe me when I told him that it's 2025. So this brings up the first decision point of this case of, do we involuntarily hospitalize KM? Well, from an autonomy perspective, KM does communicate a clear and consistent choice of discharging home, and this is actually what his parents want for him as well. but he displays little insight into the mental illness and the current situation. So displaying little insight or not recognizing mental health symptoms in oneself is a term that we refer to as anosognosia. I think I had that on the previous slide and didn't explain it. From a beneficence standpoint, I strongly believe that KM needed treatment with antipsychotics. I was highly suspicious for a psychotic disorder. This could decrease the risk of further bodily injury, given that he was violent earlier that day. And the early detection and treatment of psychosis can improve treatment outcomes. From a non-maleficent standpoint, we have to acknowledge that involuntary psychiatric hospitalization can be really uncomfortable. It can be lengthy, and it can lead to a lot of financial costs. Medications, if he does take them, can lead to side effects, and he might have to wait in the emergency department for a long time before he's finally able to actually get to a psych hospital. From a justice perspective, the patient appeared to pose imminent risk of harm to others. So to me, he met Section 12 criteria. Now, this is, I think, where the letter of the law versus the spirit of the law comes into play. One could argue that he is contracting for safety. His parents feel safe with him coming home. He was home for the past 2 months and he didn't attack anybody except for today. And he's been with us in the emergency department for hours and he hasn't, lashed out. He didn't need restraints. So you could argue either way, but, here I really thought that he does meet Section 12 criteria. Other considerations are that psychiatric beds are limited. Perhaps a psychiatric bed would be better used for a patient who would be accepting of help. And every hour that we are keeping KM in our emergency department is another cost of manpower, of resources that UMass is providing. So as far as personal motivations, my shift is ending in 30 minutes. I didn't get a chance to have dinner, so I'm hungry. The clinical social worker disagrees with involuntarily hospitalizing the patient. Again, the parents feel safe with him coming home. And it would be easier to discharge KM home at this point. Well, decided to proceed with involuntary psychiatric hospitalization, felt that beneficence and justice prevailed in this case. But we have to acknowledge the trade-off of violated autonomy, discomfort, potential medication side effects, limited beds, financial drawbacks. And again, as a team, we didn't have consensus right away, but after meeting with the patient and talking with the family, we were able to reach consensus that this really is probably the best course of action for KM at this point in time. So I went back to the emergency department in order to talk with KM about what we're going to do. And as I start, giving a long prelude as to why he would not be able to return home at this point, he started appearing rather anxious and started looking around and really eyeing the exit. So at this point, I'm concerned that he might try to elope or run away. So do we lie about the disposition? Do I lie about the disposition? Now, okay, I fully understand that lying is not something that we usually put pluses and minuses to. I am being intentionally provocative here to keep you guys engaged. We're about halfway through the presentation here, and I'll tell you why this is technically a lie, and I'll tell you what I ended up doing. So, from an autonomy perspective, patients have a right to be kept informed about their medical care. KM wishes to discharge and his parents wish to discharge. And it is at this point that I'll point out that because the mental status exam and all the information that we had suggested that KM's decision-making capacity for making medical decisions such as discharging from the emergency department or getting admitted to a psychiatric facility may have been compromised. So in this case, we look for a healthcare proxy. There was no healthcare proxy on form or in the records. He is not married. He doesn't have any adult children. So by default, his parents would be the surrogate decision makers. And both the patient and the surrogate decision makers are saying that, again, that they want KM to return home. From a beneficence standpoint, lying might keep KM calm for the time being and decrease his risk of elopement, or at least that would be my hope. From a non-maleficence standpoint, telling the truth might push KM to elope, and lying could hurt our therapeutic alliance. And I'm not sure if justice is clearly applicable here, but there is a small chance of lawsuit by not telling the truth. As far as personal motivations, my shift is ending in 5 minutes and I still have notes to write. I am still hungry and I don't want to mobilize security and medical staff to forcefully restrain an eloping patient because I fear I would look incompetent. Now, it's less important whether that is a valid fear, right? But that was what I was feeling in the moment, and it may have impacted how I decided to act. It was kind of a spur of the moment decision, feeling like non-maleficence was the most important principle here. So I did end up lying. I knew what the disposition would be, that he would be going to inpatient psychiatry, but I led him to believe that we don't know yet. We're still trying to come up with a plan. What I did to mitigate that lie was I went and spoke with the resource nurse, and we transferred KM to the emergency mental health part of the ED. The advantages of that is that it has locked doors, so much harder for a patient to elope. And I did break the news to KM at that point, and he got quite upset. But eventually he calmed down, saying like, oh, well, this is all on tape, and I'll be able to get the tapes, and I'll be able to show that my parents are simply trying to frame me. So thankfully he didn't try to elope, but if he would have, being in EMH is the safest place to do so, or to try. His parents are still expecting KM to come home though. So what do we do about that? This is our next decision point. Do we discuss this position with the parents? KM did not really give us permission to talk with his parents, but he's also lacking capacity. So parents are the default surrogate decision makers here. But as Section 12, by definition, you don't need someone it's involuntary, right? You're being held against your will, or you can be held against your will. So technically, I didn't need to speak with the parents about this decision that was going to happen anyways, because again, and KM had refused initially permission for us to talk with the parents. From a beneficence standpoint, getting the parents on board early can improve prognosis overall. When he's all done with whatever sort of interventions, assessments, treatments we might recommend for him, however much time he might stay with us, ultimately, he's going to return to the community, to his support group, right? So if his support group is on board with psychiatric treatment, well, then that'll make it much more likely that KM would get the treatment that we think he needs. Discussing with the parents now can make it easier for the hospital team once he does get admitted to a psychiatric facility. So also, making it easier to come up with a safe discharge plan once he finally does reach a psychiatric hospital. From a non-maleficence standpoint, by talking with the parents, if KM finds out, that could actually worsen the therapeutic alliance. But I feel like this was less important here because I wouldn't expect KM to remain in EMH for too long. From a justice perspective, I feel like this is kind of a gray zone for HIPAA violation. Again, talking with the parents about this when you don't really need to, and the patient specifically says, you're not allowed to talk with my parents because they're the ones who are trying to hurt me or frame me or mess with me. I don't know. Maybe, I'm not a lawyer, maybe it's not a gray zone, but to me, it felt like a gray zone. As far as my personal motivations, my shift ended 20 minutes ago, and I really don't want to have an argument with the parents because, again, they want KM to come home. But I had this strong sense that this is the right thing to do. So I did end up calling them, and it was emotionally heated discussion, but I think I did the right thing by talking to them. So this is where I'll take a moment to talk about capacity. Didn't have a great spot in the lecture for this discussion, but it's incredibly important as far as ethics are concerned, and especially important in psychiatry. So whenever possible, try to maintain patient autonomy. And if a patient is lacking capacity, try to determine who the surrogate decision maker is. Even when we feel like our intentions are good and that we truly know what is best for the patient, it is critical that patients keep their that patients or their healthcare agents are part of the medical decision making. Surrogate decision makers should be kept in the loop about what's happening. It seems that we oftentimes forget to keep those surrogate decision makers informed. And really, that's understandable. The patient is there, the healthcare agent might not be, and I'm using healthcare agent and surrogate decision maker interchangeably here, so bear with me. But the healthcare agent is not there in person. You have to go through the trouble of getting their phone number, hopefully getting them on the phone, or leaving them a voicemail and trying to reach them later. However, it's still really important to do that. As a society, we highly value autonomy, and by the way, so do the courts. And keeping the decision maker in the loop, it can help build a therapeutic alliance with them. And finally, healthcare decision makers are allowed to make what we might consider to be bad choices, right? So I mean both this for the patient or their surrogate decision maker. And this can be really difficult for us as clinicians when we feel like patients are making choices that are going to be harmful to them. So for example, if you have a patient who has alcohol use disorder and is being admitted to the hospital with because of a failing liver, and they're refusing addiction services, you might strongly disagree with their decision there, but as long as they have capacity, they can make that decision. It's quite rare, at least in my experience, that the surrogate decision maker might be lacking capacity or otherwise not be able to perform the duties of being the surrogate decision maker. Just be really careful with that. It's a high bar to clear in order to legally go against what they say, and you need to go in front of a judge in order for that to happen. And the reason for that is to help designate someone else as the surrogate decision maker for the patient. It's never just us, at least not from a strictly legal perspective. All right, so back to KM. He was psychiatrically admitted the following day, so thankfully he didn't have a long wait time. His parents' opinions had changed. After multiple conversations with the primary team, the parents said that KM must agree to take medications both at the hospital and at home in order for him to be able to return. But KM continued to refuse medications, and initially he didn't have a really good plan for what would happen if he was to not be able to return home. But eventually he did develop this plan that, okay, well, he can grab his car, go pack up his stuff, and go to a shelter. Which, fair enough, but also keep in mind this is someone who doesn't have financial means and who has never lived on their own before. But technically, this can be considered to be a safe discharge plan. And a judge, this went in front of a judge again because the patient was admitted against her will, and ruled that KM cannot continue to be held in the hospital, at least based on limitations of the Section 12. So technically a decision point, right? Do we discharge to a shelter? From an autonomy perspective, KM wishes to discharge to a shelter, but his surrogate decision makers disagree with that. From a beneficence standpoint, KM can reasonably be expected to be able to function better and be less violent if the psychotic disorder gets treated. From a non-maleficence standpoint, occupational therapy evaluated KM and determined that he would need assistance in the community. In other words, it's not really safe for him to live independently. And there's also the risk of KM becoming violent again, like he did with his parents when he believed that they took his keys away. From a justice perspective, a judge is mandating discharge based on the limits of Section 12. And that last bullet point, that overrides everything now, right? And this is a situation where, as clinicians, we might feel very strongly about. We're being forced to take a course of action that we might disagree with. We might wish to vehemently argue with patients, with their surrogate decision makers, and/or the judge, and to argue our point why we should be allowed to do what we think is best for the patient. I experienced that as anger towards the legal system because I had this strong conviction that KM needs inpatient treatment and feeling like we have failed KM and his parents. So in my own case, it looks like my first instinct in order to deal with these emotions was jumping to clairvoyance and omnipotence, like the idea that I can see into the future and that I can impact things that I might not necessarily be able to impact. There's no way for me to really know what will happen to KM after he leaves the hospital. Perhaps he will need another hospitalization, and maybe that'll help him build some insight to at least try medications. Maybe no matter what we would have tried in this case, perhaps we could not have made KM better. We can make recommendations for treatments, but how often can we really guarantee that something is going to work? And by repeatedly taking KM's autonomy away, perhaps he would have become even more resistant to trusting mental health providers and ultimately more resistant to receiving treatment. It's opportunities like these where we feel strongly about a case that there's probably the strongest learning opportunities. So perhaps this feeling of clairvoyance and omnipotence, perhaps that was actually there all along. Maybe it impacted the decisions I made earlier in KM's case. That's something for me to reflect on and to work on, going forward. But the bottom line is that we do our best with the given information at the time, and we try to learn from each patient encounter, especially the ones that make us feel the most strongly. Some practical suggestions: be deliberate in your practice. Continue taking the time to work on your virtues. Thinking about ethical issues as you encounter them is a way to practice that. So using this framework for medically complex issues is one way to practice. Be honest with yourself and with your patients and with your colleagues. This requires a certain degree of vulnerability, but it breaks down barriers in communication, and it in turn gives permission for others to be honest with you. Consider your personal motivations without shame or critique. This is something that I've tried to model during this talk, even from the beginning of talking about conflicts of interest. You can choose to make changes in your thought patterns or your feelings, but being self-critical makes us more likely to ignore those issues rather than try to improve them. So that's why it's important to try to be non-judgmental towards yourself. Discuss difficult situations with your team. See if a consensus can be reached. There are likely things that you haven't considered that someone else might have. And even if you don't reach consensus, giving everybody the room to share their insight and to give their 2 cents will make you stronger as a team also. And finally, if you come across a situation you really don't know what to do, it's always okay to ask for help. Perhaps one of your colleagues has come across a similar situation and can help guide you. And most academic institutions, UMass included, have an ethics consultation service. Dr. Scott Bateman, who helped me with this presentation, is the head of the consult service here and of the ethics committee. So he's been incredibly helpful to many teams as they've come across really difficult situations. Dr. Varkey made this diagram, which I think illustrates what we talked about nicely. Our morals and ethical principles and professional virtues affect the way that we feel and interact with patients, which then translates to the care that we provide. Now, Dr. Francis Piabody said the following about 100 years ago. One of the essential qualities of the clinician is interest in humanity, for the secret to the care of the patient is caring for the patient. For the secret to the care of the patient is caring for the patient. If you forget literally everything else we talked about today, just remember this one slide. Choose to care deeply, everything else falls into place. If you really care about your patients and the work that you're doing, you're bound to become more curious and you're bound to be more trustworthy and conscientious about your work. In brief review, we discussed fundamental principles of medical bioethics. We probed the classic trolley problem and observed how old philosophical debates are making their way into medicine still. We discussed how even rudimentary framework can be used to make ethically informed decisions in complex clinical cases. And we talked about how deliberately fostering professional virtues can help us better care for patients. Quick shout out to Dr. Scott Bateman for sharing his expertise in ethics and offering feedback at all parts of this presentation. Dr. Jeffrey Balul for the consistent mentorship and gently challenging my unconscious biases over the past 4 years and making me a better psychiatrist as a result. To Dr. Spadija and Dr. DeGrush for supporting us as we do these sort of talks at the end of our residency training. And to my partner, Dr. Emanuela Tsagaraki, who's given me really good feedback for this presentation itself and who supported me ever since we met. Thank you. I'll take any questions.
Thank you, Boggy. That was wonderful. And I was thinking how you took a very, and sounds like this was a slightly altered, but kind of a case you saw in EMH. I mean, we see this every day, basically, with little variations, right? So a very bread and butter case, and you broke down each piece individually and really presented it in a beautiful way, so thank you. My question here, or sort of comment and then question is, I was thinking about perhaps the non-maleficence in that moment where you were debating, am I going to tell him that he's going to go inpatient or not. And the other piece that I was thinking as you were talking, you were mentioning, I don't want to mobilize security and I don't want to look incompetent. And I would validate that. That is a scary thought as a physician. We're supposed to be, running the show, but also the safety aspect, because you described a 20-something-year-old athletic build young man who's looking for the exit. And so I could easily put myself in your shoes and think, oh my goodness, if I say that this guy is going to go in, who's in the line of his egress, basically? And unfortunately, we hear stories about this a lot. And I don't mean to imply just psychiatric patients ever. On medical floors in the emergency department, and that has been part of the news as of late. So I had one additional thought there, is perhaps that's a piece of non-maleficence. If we can still get him what he needs and try to meet his needs and also make sure that none of our medical professionals get hurt, that might be something else to think about. But then this made me think about the question of, if we say, well, we're going to figure out what else we can do for you, it's not quite a lie, right? It's a little euphemistic, which made me think about when we think about kind of euphemistic prescribing, which then I was remembering Dr. Ruska many years ago did a really great presentation on talks like this, these sort of talks, right? And I was wondering if that came into some of your thought process here when we sort of don't give the exact, answer. For example, I might prescribe, I'm using an example here, but we might say, we're going to use this quetiapine to help control your anxiety to a person with chronic schizophrenia. And what are the ethical implications of that? So I know that's a pivot from your talk, but I was just curious if you came into some of that discussion with this.
Yeah, no, I think in psychiatry, we very frequently venture into this gray zone, where it's not too far removed from depending on partially on the intentions behind it, this could be considered ethical or maybe less ethical. So I think bringing awareness to that and just considering from as many perspectives as possible, that's what can inform us to make ethically informed decisions. And I think the more one does this, the more points you can actually add to that chart and consider things from multiple different perspectives. And, each time you come across a case like KM's again, I'll already have kind of a starting point for something like this. Yeah, so I agree with what you're saying. And yeah, bouncing things off my colleagues has been a really good way for me to develop my own thinking. So thank you for your question.
Yeah, thank you for this great presentation and discussion. And I think it's really useful sometimes to take these kind of bread and butter cases and look for more than just bread and butter. So but one of the things that I was thinking and just challenging the notion that we kind of think we know the right outcome here is, how does kind of our knowledge of the system play into our ethical decision making? Because you could take a step back here and say, this outcome was completely predictable in terms of him being hospitalized, meeting his 3-day, assessment, and being discharged against, everyone's thinking advice. Not only is it predictable because we know the system, but it's predictable because it happened last month when the same exact course happened. So, at what point does that influence our thoughts about, is there another approach here, or is there another way to engage the patient, the family, rather than kind of rinse, repeat, recycle, whatever the analogy is? So anyway, just throwing that out there to discuss.
Yeah, I think that impacts us probably constantly, right? Like we might know that someone needs to be inpatient in order to be kept safe, but we also might know that that could end up being like sort of a waste of time if they're not engaging in any sort of treatment, and they're not really much better by the time that they leave, or if the decision is completely taken out of our hands, and perhaps like a judge says you can no longer hold them and you have to discharge at this point because correctional psychiatry is not quite like practicing psychiatry in a correctional facility. But I think keeping all those things in mind, and perhaps it changes what we emphasize in our discussions with patients and their surrogate decision makers, changes perhaps what we emphasize when we talk about treatment and next steps, maybe makes us talk more about what will happen after discharge, or keeping the door open for them to return, even if they don't think they need help now, perhaps later, knowing that they can always return. So I think it always plays into our decision making, and I do think that having that cultural knowledge, right, being at an institution for some time and getting a sense of how the laws in Massachusetts work, or how UMass as an institution work in different hospitals around here, can help you make more informed decisions, and I think that's really valuable.
Yes. First of all, a great presentation, thought-provoking, very well constructed. So good job on that. I had similar thoughts to Dr. DeGrush. When you were, especially on that, the pivotal point, I think, in the vignette is whether to tell him or not, because that usually is about the relationship with the patient and informing him what's going to happen. And I really don't believe that you lied to him. I really think what you did is you used a tool, and you are a very well-trained psychiatrist, and you used the tool that we're all trained in, which is to use the language in a certain way that, sure, it's vague, it's kind of open-ended, but this is what we get trained to do. Sure, it drives people in our personal life crazy, because especially if when we don't take that hat off. But this is really, we don't have a stethoscope. This is a tool we have, and because you technically said nothing. There was no lie in there. You said, what was it? You said, you got to give me some time. I'm going to figure out what to do to help you, which is exactly what was your intention. And honestly, had the setting been different, maybe if the patient was already in EMH and you know that they cannot really bolt and you will have support, you probably might have said something different. Yeah. So this is, again, the setting is very important because there are a lot of competing factors in these ethical decisions that we make. So that's my first comment. The second one is, I'm so relieved and glad that you did not really you did not spend a lot of time talking about the trolley problem. Honestly, listen, this biomedical ethics paper, all of them start and end, and sometimes most of the meat of the discussion is about the trolley problem, and it's a fabricated, factitious problem. This has nothing to do with real life. Most of the things we face in real life, there's a lot of competing factors, there's much more nuance. However, it's a good instrument. It's a good tool to open the Pandora box, to make us question these or sit with these uncomfortable scenarios, uncomfortable questions, and then to kind of guide us more into this framework, the bioethical framework, which is, it's a framework again, and we're all different people with different moral values. There's no shame in that. We all have different backgrounds, and I'm glad you started with that. And the last thing I would say is very important point you made at the end is discuss with your team. It's because ethics is really kind of a consensus matter. It's not, it's not an individual matter. Whenever possible, fortunately, you might find yourself sometimes lonely and isolated without a team. But if you have a team, or try to reach out to people with these decisions, but great work.
Thank you so much. As to your first comment, it felt like I was lying in the moment. And again, I know I was being a bit facetious by using that language here. And I did try to mitigate, and it was still important for us to share the truth with KM. I just waited for him to be in a better place for that. But yeah, I agree. It was never my intention to lie per se, but it felt like a lie in the moment.
Well, first, you have a very clear way of talking us through your thought process on a typical decision that one makes on a call. A few comments in escalating levels of interest. First, this is just a historical comment. There was a time, probably maybe Tony was still already on faculty, but there was a time when we had quarterly ethics cases discussed at department meeting, one of our forensic people, and used the same chart you were using and got the whole department to discuss a decision that was being contemplated, and it was a very interesting exercise. Okay. Second comment, which is also just a minor one, one use of the trolley problem that has been very interesting is that no matter who considers the question, their ventromedial orbitofrontal cortex lights up on functional imaging. In other words, everybody who does this, who's able to consider the thing in detail, uses the same part of their brain. And that's kind of intriguing. But that's not That's neither here nor there. The most interesting thing about this is you just kind of hinted at it. Several years ago, we held a collaborative kind of online meeting. This is before the days of Zoom, with the residents in Athens, Greece. And our residents and the residents in Greece were each polled beforehand about their ideas about, they had to force choice the levels of which of the four principles of medical ethics were number 1, 2, 3, 4 when they make a clinical decision. We then gave both groups a clip to review that had to do with involuntarily hospitalizing somebody with a kind of sleight of hand, so that it wasn't entirely clear to the patient. And then the decision about involuntary medication. And it was very interesting that even though you said that we value autonomy more, there was no question that 100% of our residents considered safety first, autonomy second. The residents in Greece were horrified that our second-year residents can sign a Section 12 and deprive someone of their liberty, where in Greece they have to go wake up a judge. No doctor can do it. It has to only be done by a court. And they were absolutely overwhelmed at how totalitarian our psychiatry system is, that and how paternalistic that we take these decisions away from people. Like a junior resident in the middle of the night does it 4 times, maybe more. Doesn't even, and then, if they wake up the attending says, okay, and goes, but sometimes they don't even wake up to say, okay. And so our cultures are completely different in terms of the order of medical ethics principles in our decisions. You hinted at it, but I think I just wanted to kind of underline the point.
No, thank you so much for those comments. And I'm often in awe by how much power and privilege we get with being psychiatrists. And I think, reflecting on that frequently will help us, make ethically informed decisions. Also, a quick comment on the trolley case. Dr. Jeffy Balul had recommended that paper to me, and there were probably like at least 7 different iterations of the trolley problem, and each time I would read about it, like, oh yeah, this makes perfect sense. This is exactly what should be happening. And I read the next iteration and like, okay, never mind. So I just wanted to give you guys kind of one taste of that, because I think what came across is that moral intuition is great. It can be easily wrong. We don't know it's wrong until we discuss it or we consider it further. And that ultimately will make our moral instinct better over time by deliberately engaging in that.
The most important thing is you don't just have a yes, no answer.
Yeah.
Pull the lever.
Yes.
Don't pull the lever. Whatever.
Yeah.
So we have a question from Zoomland. Do you think the ethics or the weighing of the principles changes from state to state, especially considering the laws are different in each state?
Yes, absolutely. And we saw with that very last decision point after the judge had mandated that, KM could not be held in the hospital, even though autonomy is usually our first principle in the hierarchy, or maybe sometimes non-maleficence can override that. In that case, justice, completely overrode everything. So I think laws absolutely can have a huge impact on the way that we practice psychiatry and can force us into certain decisions. And I think just the trick is to not feel defeated by that and still take opportunities to learn from it.
Another question from online. Why was the conversation with the parents heated?
Because the parents did not want KM to go to a hospital. They saw this as a misunderstanding and they felt like it would be safe for KM to return.
Okay.
Awesome presentation. I really enjoyed it. I've been thinking a lot about moral injury recently and like how it's framed around burnout. What do you think about these ethical principles conflicting and causing more moral injury? Do you think it's like a big factor in doing so?
Yeah, I think about it a lot. Ultimately, I think we just work within our circle of influence, and that's all we can do. And this is where defense mechanisms can really come into play and be quite helpful, right? Perhaps like dissociation is not always good, but in cases where you have no control over the outcome, perhaps dissociation is not so bad because it lets you like keep focusing on your day-to-day work. So sorry that I don't have a more hopeful answer to that.
Hey,
Hi.
great talk. I'm wondering, I was thinking about like the cultural component of things and how, like we talked about, and especially like different cultures around the world, how family really takes care of their like sick loved one or whatever it might be. And, you know, I don't know the situation with this patient, but how much of that, I think, if a family member is like, look, this runs in my family, this happened to my brother, whatever it is, like, I know how to take care of this. I know that, like, this is how we do it from my home, from my place. How would you kind of use that information in your decision making, I guess?
Yeah, so something that I've become more aware of as residency has progressed is that autonomy is just as important when it's the patient themselves making the decisions versus their surrogate decision makers. So just like we should take a patient's cultural background and preferences on how they like to exercise their autonomy, we should do that for their surrogate decision makers also. For example, some patients might want their loved ones or people who are important to them be much more involved in the decisions that they're making than perhaps we would have the instinct of allowing for, right? Like, you don't need to discuss this with your mom and dad. Just tell me like what you want to do. Do you want, to take medications, that kind of thing. So I think it's really important to consider those cultural aspects and to apply them as much as possible and try to maintain autonomy and give surrogate decision makers as much respect for their autonomy as we do for the patient for whom the decision is being made.
All right. Thank you very, very much. Excellent talk.